Pleasure to be here in Houston. Tom, this is snow, if you still remember that white stuff on the ground. We get it every once in a while, but you'll forget it over time. So this has been a fun journey for me developing this team, and it really, I think historically, I'm not a lifer at Mass General, so I came here as an outsider about 7 years ago. Very large, big city hospital, lots of patients, lots of really sick patients. And when I started to see how pulmonary embolism was managed, it was kind of all over the place. So within, really a very short time of arriving there, it struck me that something needed to be done to try to organize this. And I'll start with a case and see what you think about this. And this, is one of our sort of typical cases that I think illustrates why having an organized team is important. So this is a 56-year-old woman, a week after knee replacement. She had a previous PE in 2005, and in fact was prophylaxed after the knee replacement. But on the day of the admission, she had fairly acute onset of shortness of breath, lightheadedness, and felt dizzy but didn't quite pass out. Came to an outside hospital where she was found to have blood pressure of 104, tachycardic to 112, and was somewhat hypoxic and tachypnic. So not subtle. We don't need fancy gating for this one. Sorry. No, but this person had obviously significant bilateral PE with a saddle, and echo was also done. This is by the time she got to us, and you can see this clot in transit, which always gets our heart rate up above the patient's in many cases, because we see this little sausage flopping around across the tricuspid valve. And her RV was clearly quite enlarged and hypofunctional. So we have a patient who has come in fairly acutely, previously healthy, with obviously a large acute PE, clot in transit, neuromotensive on nasal oxygen, but with a tachycardia and some tachypnea. So what do you do? I'm sure you've seen very similar patients to this. Well, you have choices. You could say, heparinize, pray, and wait. You could give full-dose systemic lysis right out of the bat and said, well, I'm worried enough about this clot, I'm just going to hit her with 100 TPA. You could, since, we have surgeons here, you say, we have to operate, let's go in and remove this clot, take the clot out of the heart and the pulmonary artery. But this is a, younger woman, she doesn't necessarily want a sternotomy, she doesn't need it. You could put in a catheter and do thrombolysis, or you could go in and extract the clot with a catheter from the heart and the pulmonary artery. So you can think about in your minds what you would have done or what you would do in a case like this, but I think you'll agree that there are probably a number of different options. You've already heard about the mortality risk and why we really need to think hard about how to treat these patients, that early mortality is high, and once a patient gets into this, what I call death spiral of RV failure, you may not be able to get them out of it. So you don't want to guess wrong. Once the RV dilates and once you get a little bit of drop in RV, right coronary perfusion, which worsens RV ischemia, you set off this vicious cycle that can really lead to a bad outcome. We also know very clearly that, and you've heard this from a previous speaker, that although more serious PEs, i.e. massive shock-like PEs, are less common in prevalence than the very common lower severity PEs, they're worse. So this may be a relatively small number of patients, but much more serious. Lots of different choices as to what you can do. Unfractionated heparin, continuous IV heparin, or intermittent sub-Q heparin, low molecular weight heparins, direct inhibitors, et cetera, et cetera. Thrombolysis can be given systemically, catheter-directed, pharmacomechanical, so chop up the clot, slice and dice it, and give a lytic. You can go in and aspirate with a variety of devices that you'll hear about. Surgical thromboendarterectomy. Then you have to think about the adjunctive treatments. You put this patient on mechanical support because you think they're quite unstable before you decide what you're going to do. When do you put in a filter? These are all therapeutic options that we have at our disposal without clear guidance on what to do when. And I think that that's a very important. We talk about guidelines, and they're very nice, but if we had clear guidelines, it'd be easy. You wouldn't need a team. You would just pull out a piece of paper and say, this patient, this is the score, let's do this. Unfortunately, that is not the case and may never be. So you need discussion, you need to think about these cases. A number of recent trials, some of which you've heard about or hear about, that we need to incorporate. You know, we have the PYTHO trial of thrombolysis and top coat. We have reduced dose regimens. This is the MOPPET trial, which was 50 milligrams of TPA, which seemed to be beneficial. We have catheter-directed data from the ULTIMA and the Seattle 2 trials. So these are all things that we will need to incorporate when you're trying to make your best recommendation. Different catheters. We have ultrasound-enhanced thrombolysis, which may offer some advantage because we're going to disrupt the clot and then allow the TPA to penetrate. And so the ECOS catheter is used quite frequently, as are other catheters. We have suction embolectomy devices, and I think you'll hear more about these from the other speakers, where you can go in there and really just suck the clot out with an extraction device. Obviously, you can do surgery to embolectomize the patient, and that has some benefit, and I think Tom will talk about this. You have ECMO, and like the Bruin, someone noticed the Bruin, so this was a patient we did. I don't know, if Tom, if you're going to talk about this case in particular, but this is one of our success stories of a guy who basically came in arrested. He was, I think he had a bypass, a coronary artery bypass, had a massive PE, ended up on ECMO, and did very, very well. You have, sorry about that, finicky, a little bit, yeah. Here we go. Oh. Hold on a second, I got this. I got this, wait a minute. You don't need any help?
Yes, sir. Computer emergency response team.
What was that? That's right. Okay, where's the little thing here? Oh, there it is, I got it. Okay, so, and I think Tom will talk about ECMO, but it clearly has a role. So how do we get all these potential options and make sense of them? As I mentioned, when I came to MGH, it was very clear that even at our institution, a highly evolved institution, treatment was all over the map. It depended on where the patient came in, were they in the emergency room, or were they in the intensive care unit on the floor. Depended who was consulted first, whether surgeons consulted, the radiologist, cardiology, and there really was no consistency in decision making and no accepted algorithm. And no way to really evaluate what had been done. And that was really the nidus for PERT. So our concept was that regardless of where the patient was entering the system, once they had been identified as having a severe PE, and we can find that in a second, what we consider a severe PE, then you would activate the team. The PERT team would be activated, and immediately, within a short order of time, you'd get the access to multiple experts in various specialties, because this obviously does cross specialties. And within an even equally short period of time, you would get a treatment recommendation from that team. So you'd be getting a team recommendation for which of those many different options you should do in your particular patient. So formally, objectively, the objective of PERT is to respond expeditiously to treat patients with massive and submassive PE, provide the best options available for each patient through a multidisciplinary team coordinating the care among these various services, and then to develop protocols and, importantly, collect data on what we're doing to determine best practices. This is quite a system here, hold on. So the flow diagram, if you will, flow map of how this works is really fairly straightforward. So a fellow, always a fellow, is the first responder. So once that team is activated, they're evaluated in relatively short order by the fellow on call for the team. then identifies the risk of the patient, does a quick assessment, and then makes the decision as to whether or not the whole team will be activated. And I'll talk about the process in a second of activating the whole team. That then leads, if that's the case, to an electronic meeting, a virtual meeting, if you will, of the various specialties involved, at which time recommendations will be made. So these posters were put up around our hospital when we first started this team in 2012, and basically describe the kind of patients we were talking about here. Very important to note when you're setting up this team what kind of patients you actually want to be called about, because be careful what you wish for. The concept was large pulmonary emboli. Now, obviously, there's no strict definition for large, but basically, did the patient have any abnormal vital signs, anything that worried you? Obviously, the signs you've heard of, suggesting RV strain, intermediate risk, but even anatomically large PEs might worry someone enough. I think the short way to answer the question is any PE where you really are worried enough that you really don't know what to do and you want some help. Not every one of those calls will lead to the full team, but those are the kind of things that we assess. And you simply dial this number for PRT, which activates the pager of the PERT fellow. We suggest that the standard evaluations have already either been ordered or done. But I can tell you, we've had many cases where they haven't even had a confirmed diagnosis of PE. Now, that's nothing we encourage, but there may be individual cases, patient in the ICU, they can't go down for any imaging, sick as hell, they develop acute hypotension, bedside echo shows their RV's blown, you don't have another explanation, you're like, heck, I think this patient's had a massive PE, let's call the PERT team. That's happened on occasion without any imaging. I can tell you, as an aside, that none of those patients turned out to have pulmonary embolism. At the end of the day, they were septic or some other explanation. So just an interesting learning point. Okay, anyway, so the fellow, the answering service activates the fellow's pager goes off. They'll do the initial evaluation and then make that determination if we're going to activate the whole team. If that's the case, we then utilize this web-based virtual meeting concept, which is commercially available, HIPAA compliant, etc., where the fellow basically loads up the images. It's essentially a desktop sharing. So we'll get an email saying, or page saying, check your email, there's a PERT meeting in 20 minutes. We'll then go on to our email, whether it's on a phone, computer, whatever, click on the link, and there it is. And you're basically looking at the fellow's screen who's sitting in the hospital, scrolling through the images, just through the hospital system. We then have a discussion after looking at images, echoes, etc., and come up with the recommendation, the treatment recommendation. So these meetings are efficient, they're quick, and usually pretty well attended. A typical PERT meeting will be, vascular medicine, pulmonary vascular, my group, possibly emergency physicians. The accepting team, which we found to be an important concept, is that the team that will be accepting the patient, let's say in the intensive care unit, be part of this call. Potentially cardiac surgery, often hematology, and you'll hear from Dr. Rozovsky in a few minutes. Those people are typically on the calls. Now, it varies from a lot of people to few. So the number of people on a call is anywhere from 3 to 12, maybe, on each call. The calls last about 15 to 20 minutes on average, sometimes a lot less. And then we have our recommendation. Very importantly, as part of our PERT initiative, we have a follow-up clinic. So we've given our recommendation, gets instituted, patient goes through the hospitalization, goes home. They all are seen in a follow-up clinic. One of the very important questions about these patients is what happens afterwards, and how many go on to develop chronic problems, how many resolve, things like that. So they're all seen in this follow-up clinic, which is also multidisciplinary, and we're collecting a lot of data on long-term outcome after large PE. few publications have come out on this. We most recently published our initial 30-month experience with this program, with some data. And this is just a little bit of data I'm showing you. Most of these patients come through the emergency department. Some come through from the intensive care unit, some from general medical floors. So that's the breakdown. The severity of the PEs that we've seen are shown here, with the majority of patients having some evidence of RV strain. So we are seeing the bigger, more serious PEs. Occasionally we'll see small ones, but for the most part, I think we've kind of hit it perfectly, the type of cases that we're seeing. And many of these patients, in fact, about half of them, are admitted to the intensive care unit. This is just the overall breakdown of low, intermediate, and high-risk patients. And you can see that the majority are what we considered intermediate or high risk, but there are some patients who are low risk. And that's kind of been relatively stable over time. Maybe the lower risk patients are going up a bit more recently. But it's a reasonable distribution. This is just overall outcomes, 30-day mortality outcomes, since the PERT initiative was started at Mass General. And you can see here that, maybe we're doing somewhat better than at least what's in the published literature. Not a perfectly fair comparison because it's a different time, different institution, et cetera. But I think our overall mortality for patients with very serious PE is relatively low. The question that would get asked is, does this program actually save lives? That's something we can't necessarily prove, but we're not randomizing people to PERT versus no PERT. But I think at least compared to historical controls, we're showing some advantages. I think that the other advantage to PERT is simply the process itself, and the way that we've systematized or simplified the management and approach to these serious patients, I think has really been very enlightening and has been very well received, let's say, or, not just at our institution, but around the country. This is just, up until 2015, a breakdown of what we've actually do with these patients. One might think that the PERT, having such a program would just lead to more procedures. We are doing a fair number of interventions in these patients, but the vast majority of patients simply were recommending anticoagulation alone. But even in that, I think there's some reassurance that it's a group recommendation, because these are not always clear-cut cases, and we all lose some sleep over the patient with a large saddle PE who we've recommended just sit on them overnight in the ICU. Most of the time, those patients do well, but we've had some, epic cases where the patient crashed, and we had to do a salvage thing and even deaths. But having had the group recommendation that this is a patient that we would be conservative with, I think was reassuring. Finally, we're taking this, on the road, so to speak. And this is a fun little map of what we call the PERT Consortium. So a few years ago, we started a yearly meeting, and it generated a lot of interest. This is the kind of program that really does resonate around the country. And so this is just a taste of people who are at that consortium meeting. In other words, who want to or have formed their own PERT programs. And this is just a map that we came up with. We have a separate group called the PERTconsortium.org, a website, and I would certainly encourage you, if you're interested, to get involved in this really nationwide and actually worldwide consortium made up not just of academic centers, but even some community hospitals. And this is just a little bit of a cross-section of how many activations these teams are seeing. We're in the 15 to 20 per month. Other centers, it's a lot lower than that. Anyway, finishing with so that's sort of the overview of what PERT is, how it works at our institution, and the concept of a consortium. So remember back to our patient who had what we might call high intermediate risk. who also had mobile clot in the heart. Large PA clot burden, RV dysfunction, moderate hypoxia. So you had your treatment options. What would you do? Well, this is somebody that we met and decided that we would try to extract the clot from the heart. So I think you'll hear more about this in a few minutes, but patient had a suction embolectomy using this angiovac device. Just to show you, it is not something you want to do at home. It involves a fairly large team of people, perfusionists, et cetera, to put this device in. It's a large catheter. And we're able to extract quite a bit of clot out of this patient's right ventricle and right atrium. The decision was made to just heparinize at that point rather than give lytics. The patient was actually quite stable and was sent to the ICU, but really over the ensuing 6 to 8 hours didn't look good. Continued to be very tachycardic, short of breath with even a little bit of movement in bed, oxygen requirements. So the following morning, we placed bilateral ECOS catheters. She got a total, I believe, 20 milligrams TPA through those 2 catheters over the next 10 hours, continued IV heparin, and by 4 hours into the TPA infusion, she was already looking better. Heart rate abruptly dropped to the 80s, O2 saturation 98%, and her RV function by day 2 looked really good and went home on day 12. So a very good outcome. What would we have done without the team? Hard to say, but I think the team approach in this case, a complicated case, needed multiple interventions, was very reassuring and very satisfactory. So this is the last slide. This is the PERTconsortium.org website. We have yearly meetings in Boston. By June, we should have Houston-like weather. So if you're interested in attending, it's a 2-part meeting. The first part is the consortium, and we've talked to some of your leadership here about how to join that consortium. Then we have a CME meeting similar to this one on pulmonary embolism over a couple days in late June that everybody's welcome and invited to attend. Thank you very much.